everyone. Welcome to our webinar on PrEP in Medicare. I'm Leslie McGorman, the Director of Policy and Strategy at AIDS United, and we are co-hosting today's webinar with the HIV and Hepatitis Policy Institute. We have a lot to cover today as we focus on the potential challenges and opportunities with the CMS proposal to transition Medicare coverage of PrEP, both daily oral and long-acting injectable, from Medicare Part D to Part B. As a quick refresher, the Centers for Medicare and Medicaid Services first solicited public comment on a national coverage determination on PrEP in January 2023. The hope is that Medicare beneficiaries who utilize PrEP would be able to do so without cost sharing. Most recently, CMS released a technical FAQs for pharmacies document in preparation for the final NCD to be posted and effective in late September 2024. We are very fortunate to have CMS subject matter experts available for the Q&A section at the end of the webinar. Please note that we'll be using the Q&A function for all questions today. So click on the icon on the bottom of your screen that says Q&A and type your question. Please note that you can do so anonymously, or you can include your name, up to you, but all questions that are entered in will be visible to everyone attending today. We will get through as many questions as we can, so please feel free to ask them throughout the discussion, even if we don't sort of assign them to panelists and so forth until the end. It's helpful for us to sort of organize the queue if you enter them throughout. So without further ado, it is my absolute honor to welcome Francisco Ruiz, Director of the White House Office of National AIDS Policy, for opening remarks. You all know that Francisco is relatively new in this post, but not at all new to the work. And we're very lucky to have him leading the charge for the White House and for his ongoing commitment. So thank you, Francisco. Following Francisco... Not yet. Following Francisco, we have the privilege of hearing from Dr. Dora Hughes, Acting Director of the Center for Clinical Standards and Quality, as well as the Acting Chief Medical Officer at the Centers for Medicare and Medicaid Services. She, too, is a longtime expert dedicated to healthcare access and public health, including passage and implementation of the Affordable Care Act. So following Dr. Hughes, we will turn the webinar over to Carl Schmidt, Executive Director for HIV and Hepatitis Policy Institute, who will introduce today's panelists for a roundtable discussion. Later to invite CMS staff to offer some introductory responses, and then we will go to Q&A with each of you. So thank you again for being here, and Francisco, the stage is yours. Thanks, everybody.
Awesome. Sorry about that. The caffeine has me rolling. Buenas tardes. Good afternoon, everyone. I want to start off with the words of gratitude. First, a huge thank you to the organizers of this webinar, AIDS United and HIV Hepatitis Policy Institute. Your efforts in coordinating this event and ensuring that our communities are informed about this significant policy shift is very, very important. So thank you for that. I also want to thank and acknowledge the dedicated teams at CMS. You hear from many of our CMS colleagues today. From the very first day of my office. You've consistently responded to my calls and emails. Your commitment to providing our communities across the nation with access to essential life-saving science and services is invaluable. And lastly, to everyone participating today, all of you, thank you. Your dedication to serving our communities and your willingness to engage critically is crucial in our collective success. We deeply value your involvement and the insightful questions you bring to the table. This work has always been about elevating voices to save lives. We see you, we hear you across the entire administration. We are relentlessly striving to ensure that all Americans have the resources and tools necessary to not only live, but thrive in their fullest selves. So we gather here with a shared commitment to the Biden-Harris administration's national HIV strategy. One of those cornerstone objectives of this strategy is improving access to PrEP, a critical tool in our HIV prevention efforts. My colleagues at CMS are doing their part to ensure that access to these life-saving medications without cost sharing. This is a significant step forward in our efforts to ensure that all individuals, regardless of their socioeconomic status, have access to preventative care they need. I look forward to today's discussion. We aim to elevate the awareness of proactive steps pharmacies can take to prepare for this change and generate insights and recommendations to ensuring equitable access to HIV prevention services. Equity is a fundamental principle that underpins all our efforts in public health. Regardless of the background of circumstances, everyone deserves access to the full spectrum of scientific advancements that can improve their health and well-being. This new shift from CMS represents a significant opportunity and steps forward to accelerating health equity, particularly for communities that have been historically underserved or disproportionately affected by HIV. By removing cost-sharing barriers, we can ensure that more individuals have access to life-saving preventative medication. So again, I want to acknowledge and thank each of you for your dedication and leadership in this field. Your work is critical to the health and well-being of our communities and our country. Your insight today will be invaluable as we navigate this important policy change. And so thanks again. And I would like to invite my colleague and friend, Dr. Dora Hughes, Acting Director of Center for Clinical Standards and Quality, to follow.
Thank you, and thank you so much. I too want to start out by thanking you for inviting us to join this webinar today. I also have to say it's such a privilege to be working with Francisco. He is right when he said in his introductory comments from his earliest days, he reached out and called us. Even before we knew he was even in the White House, we heard from him advocating very effectively for all of you and collaborating on issues that are just priorities for all of us. As I would just say, at the outset, CMS is continually looking for opportunities to better meet the unique healthcare needs of our Medicare beneficiaries as part of our overarching commitment to improve the quality and safety of healthcare for everyone. And this certainly, most especially, includes individuals with HIV and AIDS. As all of you well know, we've made tremendous progress since the earliest days of the epidemic with the screening, the testing, and treatment that has made management of HIV/AIDS much like many other chronic conditions, and with an expectation for a normal or near normal life expectancy. And because of these scientific advances, we at CMS are seeing more people with HIV/AIDS reach age 65 than ever before, making them eligible for Medicare coverage. If we look back, the number of traditional Medicare beneficiaries with HIV has more than doubled since the mid-1990s, rising from about 42,000 in 1997 to over 100,000 in 2020, which is a 143% increase. And noting many of our Medicare beneficiaries are dually enrolled in both Medicare and Medicaid, providing additional opportunities for CMS to work in partnership with states. And so while this is good news, so we are very much attuned to the challenges that have been raised by many of you or other patient advocates related to the quality of care, the coverage for long-term care, medications, as well as the need for greater continuity and providers. But of course, as Leslie and Francisco mentioned, we are here today to talk about the PrEP NCD. Currently, oral antiretrovirals used for PrEP are covered under Medicare Part D, as in dog. CMS proposed a national coverage determination, or NCD, that would make PrEP for HIV a Medicare Part B, as in boy, preventive services. And we anticipate releasing this NCD in September of this year. This NCD would eliminate beneficiary cost sharing by providing this coverage under Medicare Part B. And in addition to the PrEP drugs, the proposal included coverage of up to 7 counseling visits per year, additional HIV screenings, and screening for hepatitis B. As Leslie mentioned, CMS has published a fact sheet, and if I'm able, I'll put the link into the chat or responses to the QA. We released this fact sheet to share additional information with pharmacies to help them with Medicare enrollment and prepare for this transition for future coverage of PrEP under Medicare Part B. My expert colleagues, Joanna Baldwin and Jason Bennett, are here with me today, and they will dive deep on the specifics and answer questions that you may have. And so I'll move it on, but before I do hand the mic back over to Leslie, I would note that CMS is increasingly collaborating with our colleagues at the federal, state, and local level as well as with community organizations and healthcare providers to improve access to care, promote health equity, and enhance the well-being of all individuals living with HIV/AIDS across the care continuum. Your insights and feedback have been invaluable to us, as shaping our work, our policies, our programs, and we thank you for that. And so with that, I'm going to turn the mic back over to you, Leslie. I'm very much looking forward to this discussions and the questions that you may have.
Thank you both so much, and we're really grateful for your partnership. And Carl, I will turn it over to you and the rest of our panelists. Thank you.
Well, thank you, Leslie, and welcome everyone, and really appreciate the opportunity to partner with AIDS United on this important webinar today. I have to say it's been a process, and it's been a long process, and we're still not there. We were, one of the original people who asked for this coverage determination because we see the benefits of, coverage of long acting. But to get, and we also see the benefits of zero cost sharing for PrEP users. But we've learned along the way that it's a lot easier to say something than to get it done. We learned a lot of PrEP users today, oral PrEP, are getting it, as Dora said, through Part D. And a lot of those pharmacists and those clinics don't currently bill for Part B, as in boy. So there's a process to make that happen. And that is what we've been involved in. We've been very appreciative of CMS, our federal partners, to listening to us and to make sure, because they share our concern. But while we support the coverage determination and the coverage for long acting, we're very concerned about the current PrEP users on oral PrEP, and we don't want to have any disruption in care. So we've been relying on a team of experts, and we are so happy that they are here today, because this is all a new issue for many of us. And but to introduce the panel, first is Bill Keeton. He is Vice President and Chief Advocacy Officer for Vivent Health. We have Erin Loubier, who is Vice President for Access and Strategic Initiatives for Whitman-Walker Health, and Glen Pietrandoni, who is the Chief Advocacy Officer for Avita Care Solutions. So first of all, thank you for all your advice and counsel the last year to get to where we are today. And really today is to educate people who may not know what is in store and what they have to do to get ready for the finalization of the coverage determination. So I'm going to try to go rapid fire. We have a lot of questions, and we want to get questions from the audience too. But the first question, and this is for really everyone, let's start with you, Erin. So how is Whitman-Walker currently providing PrEP to Medicare beneficiaries, and is it working?
Thanks so much, Carl, and really appreciate being here. We have about 4,200 individuals on PrEP overall, and a percentage of those are Medicare beneficiaries. And our PrEP program uses an initial visit with our medical provider, and then transitions the person immediately to our PrEP clinic, which is served by PrEP specialists, non-clinical staff operating under orders from a physician to have a quick opportunity to provide medication directly to patients. So we even pick up the medication and deliver it in that visit just to save time. And it's working really, really well. Oral medications through Part D have, not required prior authorization. They've gone through quickly. They're they're processed immediately. And we began using injectable medications in 2023. And I think that created some additional administrative work, but we're really proud of, the efforts to deliver that service to about 350 individuals.
Right, and they have cost sharing, right?
They do.
Okay, Bill, how is Vivent doing?
Yeah, thanks, Carl. And just want to echo Erin's and your thanks to Dr. Hughes and Francisco and our friends from the administration. there's been a ton of transparency and intentional collaboration and partnership throughout this. It would have been really easy to just drop this idea out there and make us all sink or swim. And I'm really, really grateful that that has not been the experience. Very similar to Erin, we've got about 2,000 individuals across our footprint in a number of different states who are on PrEP, and about 100 of them are on Medicare. So they've been traditionally receiving their coverage through Part D. Much like Erin said, the process is designed so that when that individual comes forward and says, yes, I'm ready to get on PrEP, there is minimal time for that patient to be lost to a follow-up visit that they may not be able to make it to, or confusion at the pharmacy counter, or anything like that. And so it's been a process where, as folks have come forward, there really have been really not a lot of barriers that they've experienced. And through our PrEP navigation services, other assistance programs and everything like that, if someone does identify cost as a barrier, we've been able to, find solutions to that make sure that patient, regardless of their ability to pay, is still able to access the medicine that they need.
Right. And Glenn, how is PrEP being covered now for Medicare with Avita?
So with Avita having about 70 stores around the country and about 400 clinic relationships, our patients are being served, our Medicare B and D patients are being served just like every other patient. So it's just another type of insurance, but it's a process that all pharmacists are very aware of with the Medicare D. When it goes to Medicare B, it's going to be a one-off. And then that's where we're a little concerned. But when it comes to Medicare D today for PrEP patients, it feels and behaves just like any other prescription, with an online adjudication and the support that the pharmacists give for proactively managing adherence and managing the relationship with the doctors and everything else. And of course, also with the copay, if there is need to help them with figuring out a zero copay. So right now, it almost looks like a traditional prescription.
Okay. So you mentioned Part B, and that's going to be our next question. So Glenn, why don't we start with you? So the proposed national coverage determination would provide coverage for long-acting PrEP in Part B, as we've been saying, and it would end, and that we want to emphasize that, it would automatically end the current coverage that you're already providing in Part D, which does have patient cost sharing, as we pointed out. So all PrEP Medicare beneficiaries would be able to access PrEP without cost sharing, which is great benefits. So, Glenn, what's the downside? Sounds good to me.
Let me separate oral from long-acting for just a minute. So when it comes to the Medicare D oral, if this goes into effect, most likely the pharmacy would get a rejection when they bill Medicare D for this drug, because the patient's going to have Medicare D for all their other medications. And it's a natural that the pharmacist would then automatically assume to bill D for the oral. And then we would have to get a reject from that PBM or payer or whatever that is. Now, depending on the clarity of that reject message, it could say, worst case scenario, drug not covered. Well, we all know in the pharmacy when an HIV drug or a PrEP drug comes back, drug not covered. Sometimes the technician or the pharmacist goes to the counter, talks to the patient and say, oh, that's going to be $1,800, or that's not covered, you're going to have to pay out of pocket. And so that's when the discomfort begins for the pharmacy staff, for the patient, phone calls to the doctor, the frustration that comes in. Now, if that PBM provides a nice message that's very clear, that says something to the effect of, please bill Medicare B for this drug, or something like that, something to help the process, then the pharmacy would have to be set up, obviously, to do Medicare B billing. And that's something that today, not a lot of pharmacies are set up to do this type of billing. They may be set up to do immunizations, and they may be DME pharmacies, but in the 80-something thousand stores there are in the country, it's a hit and miss of who has which type of registration. So let me just skip over for a second to the oral, to the injectables. So being that the one injectable that we have today is a limited distribution drug. So for those that may not know, limited distribution drugs are only available at certain pharmacies that are designated by the manufacturer. And so they are traditionally focused in specialty pharmacy. They focus in on injectables, and there's a way, the process already in place that a lot of people are ready to serve those patients, but they still may need to register as a Medicare B pharmacy, even though they may be experts in dispensing injectables and HIV injectables. They may or may not be part of Medicare B. So that'll be another process.
Okay, this sounds really, really complicated to me.
tried-
Bill, could you say in your words, why do you think what are the downsides of this?
Yeah. So yes to everything that Glen just said. So I want to start there. You know, what I'm worried about this meeting is for the folks who we serve. You know, for example, Vivent Health, our pharmacies, we are likely going to enroll in Part B. We understand that this is a valuable and important thing for the folks who we serve. There is cost associated with that. There are registration fees, there are software updates and billing software and system software enhancements that need to happen. The back and forth that is handled that Glen was talking about with a PBM and a doctor's office requires staffing. So at the end of the day, we're looking at an investment of $20,000 on just the software and registration side to cover all of our sites, and then probably at least another full-time equivalency employee in our pharmacy to kind of handle all of the adjudication, the back and forth. This is a considerable investment for folks who are working at organizations that are already struggling financially. Compound that with a number of independent pharmacies, and I won't pretend to be an expert in all things independent pharmacy, but I know from my work on PBM reform and several other instances, they're struggling a lot too. And the idea of having to absorb additional cost and staffing to get this done are probably significant barriers that they may not be willing to climb over. So what that means is the patient who might be going there already is going to run into a situation where there's confusion at the counter. There may be a denial, or it might just be, hey, we can't fill that for you anymore. Where does that patient then know to go to get that medication filled? And will that patient, especially at a time when we've got pharmacy deserts across the country due to closures of small and independent retail pharmacies and even some of our big chain partners closing locations, where are folks going to go to get this? So you combine the billing, the startup costs, patient confusion at the counter, and all of that sort of stuff that is all baked in living in an already extremely stigmatized space. It really, we just want to make sure we are thinking through all of the second and third level challenges to make sure we have as seamless a system as possible for these folks. Again, no cost sharing, wonderful, great. We ought to be figuring out ways to do it. These are just all of the downstream effects that we need to be thinking through.
Thanks, Bill. And Erin, I think Bill really did a good job of answering that question. So let's move on. I think you would probably say ditto. And Erin, everyone on this panel was a signatory to a recent letter authored by community-based organizations, clinicians, and pharmacists asking CMS for more clarity and flexibilities in the event that the final NCD moves forward and PrEP moves from Part D to Part B. So in the latest FAQ, which we were already talking about, what elements of the letter did they address and what elements of the letter did they not address? And are you pleased with their response? And is there anything else that they can do to help you all out?
Well, I'll give it a start, and then Glen and Bill can definitely weigh in as well. You know, we raised a number of questions, you know, in the letter, and I think we got answers on many of them, and I think that is really great. I think, you know, the clarity on, you know, what exactly would be eligible for coverage, and those were things that we were all very concerned about. The number of, times for labs and counseling sessions and those issues, those are great additions for this, because traditionally we have not been reimbursed for more than one set of labs a year for people with Medicare. So that's, those are excellent things. I think we're still we're really in the weeds on the actual process for reimbursement and what that's going to look like, especially on the injectable side, which, many of us who have been doing this, since those came out, have spent a lot of time on medical billing for injectables, and moving this to Part B, where it's, in that Part B medical coverage piece, we are concerned about, will there be any prior authorization process? Can we still run injectables through on a point of purchase, real-time basis in the pharmacy, or are these going to be something that we can't get that and we're going to need to put on a medical claim? And then the reimbursement of that, I think, are a couple of the other pieces that remain, sort of outstanding questions that we need to resolve.
Glen, any comments on the response? We did get a formal deadline on when this is going to happen. That was one of the important things that we asked for, so we could all prepare. But anything else, Glen?
Yeah, I think it was really appreciative of the consideration for the wet signature and the extra.
You want to explain what that means?
So, okay. So I think in the traditional Medicare B space, it was required that the script needed to be written, and it had to be a new script each time with no refills and a little bit more cumbersome. Again, it's a one-off, not like most traditional prescriptions might be. So that was appreciative, and then the extra refills. The date of service needs to be the same day it's dispensed and sold. So that's something that I think pharmacists will have to pay attention to. If they fill it one day and put it in the bin for a pickup next week, those dates are not going to match up. So we do have to take care of that.
And what happens then?
Well, it could be a risk at an audit to be recharged back to the pharmacy. And
They will not fill it. You have to get another script, or what?
no, it would be gone. The script would be gone, but there's a chargeback in an audit, a Medicare audit, if the dates don't match up. And going to Bill's point earlier, the costs that he mentioned, this is all with an unknown reimbursement profitability on these drugs. We don't really know what we're going to be making as a business, as well as the concern I have is that if we don't know for sure that we're going to have this NCD coming in September, many pharmacists won't invest the money to get ready for that if there's a chance that it may not happen. So I think that maybe a lot of pharmacists will wait and see, and then of course that causes the disruption in the patient care when a pharmacy is in the middle of that.
Thanks. So let's move on. Bill, CMS has indicated that they are going to finalize this in September. So what is Vivent going to be doing between now and then to get ready for this, so that your current Medicare beneficiaries who are on oral PrEP can continue to receive PrEP when it switches to Part B?
Yeah, so I mean, first things first, we're moving forward with Part B enrollment as a Part B pharmacy for all of our locations. Just to kind of echo one of the things that Glen said about the scariness of the unknown, having a sense of the decision timeline on when a clinic or when a pharmacy puts that application in, how quickly that application will be processed, and we will know. I believe there's a site visit included. There's some other steps. So we've got a lot of work to do to be ready and make sure there isn't disruption between now and, if the NCD comes out in September and it's anticipated for sometime in early 2025 for this to be live. We're going to spend a lot of time educating our entire pharmacy teams. It's important that not only the pharmacist or the PIC or the pharmacist in charge understands what's going on here, but everyone down to the technician, down to the PSR who might be, we have a co-located integrated system, making sure that, just about everyone in our network understands. But then we of course work with a number of providers that may not be one of our employees, but are providing care and prescribing PrEP or HIV medications to their patients, and they get those filled at one of our pharmacies, making sure that all of those docs and prescribers in our network are aware of this change is happening. And these are the new things that we're going to need from you. And I'm really grateful to hear about the wet signature changes and want to, of course, say thank you. But we just want everyone to kind of be hoping for the best and planning for the worst or the most challenging in this, whether it's a PA or a prior authorization challenge, a different billing challenge, all of the adjudication that can happen is all stuff that, not just our pharmacy and our pharmacists, but our finance folks need to understand and our patient educators need to understand. So it's a lot of work that we're going through right now to make sure that whenever this happens, we are hopefully as ready as possible to make this seamless for our folks.
Mm-hmm. So Erin, what is Whitman-Walker doing to get ready? And then also, do you have any advice for like Whitman-Walker, Vivent, Avita? They're in the know, they're big organizations, but so what is Whitman-Walker doing? But what advice can you give to other people around the country to make sure that they don't lose any of their PrEP users?
Absolutely. I think one of the biggest keys is what Bill just mentioned, which is the enrollment into being a Part B, pharmacy supplier. I think that's critical. We moved forward in April to file our application. We've had acknowledgement that it's pending. We understand there's a site visit, but we don't have a timeline on when, those pieces will be completed. And given what Glen said about, how many pharmacies there are nationwide and how few of them are actually Part B suppliers, I think, we may overwhelm that part of the registration process. Given the timeline, we're going to need those things to move very quickly. I did want to highlight too that, the limitations on just a 30-day fill and proof of delivery were both waived, and those were critical things that we had requested. So those were also really important. The other things that we, do to get ready for any kind of transition of pharmacy benefits is signage in our pharmacies. We meet and have any patients who are going to be impacted. We flag that to managers across departments that that meet with individual patients, often not just providers, but care navigators, insurance assisters, all the different people who are going to touch patients. I also think there's a really critical role for the open enrollment period for Medicare Part D this year, because those are part times when people are looking at their Part D plan and trying to understand whether they need to keep or change to a new carrier. This could be a critical opportunity to let people know that a drug that they've been relying on is moving out of Part D and into Part B. And this, there are notices that go out already from the carriers of Part D plans. And this could be a really crucial way that we could get some patient education done. And then I think there's a real role for, CMS just with a toolkit, things that they can provide that are patient facing, and then for providers, the documents like MLN Matters, which are reimbursement focused and usually very, very technical about what we need to do. Having one of those, for the providers who move forward with Part D processing, that would be critical.
Thanks, Erin. I think you gave a great idea for CMS and the Medicare Part D, the annual book that everyone gets, to have something in there to make a notation of that and how PrEP is moving. So Glen, how is Avita preparing, and any words of advice you can give to people around the country?
Yeah, so with our store network, we determine, who already is eligible to fill for B and where we need to go. And obviously we have in our 70 or so stores, we've got PrEP in one location, then maybe another. So we're prioritizing which stores we have got to move on first. And we've also begun the process of registering, and we noticed the 49-page document to apply for Medicare B. So that, you know, in itself times 70 locations is quite daunting. But I think, you know, the pharmacists themselves may not hear about this change until maybe their first patient shows up. So I think that working with some pharmacy organizations, and not, as you mentioned, Carl, you know, we're in the know, as you say, we're specialized in HIV and PrEP, but you know, many pharmacies maybe have 1 or 2 patients. So it's really going to be critical, I think, to understand if they're going to go forward with this. And then to Bill's point, how do we know, how does anybody know where to go? Thinking from the patient's perspective, they've just been told by their pharmacist that they can't get their drug covered. In a big city, they may be able to find something sooner, but maybe in a more rural area or smaller town may have an issue with trying to figure out where they can go. And that is a concern of mine. So we do have to get the patient advocacy groups going and the awareness in the community. And keep in mind, you know, every PrEP patient is not necessarily connected to the HIV community. They're not. So how do we get general patient organizations and healthcare organizations to be aware of this so that we can educate them?
Yeah, so Glenn, maybe you touched on the next question, but you know, from the patient, and I don't like using the word patient, PrEP user, you know, what's going to be the experience for them when this kicks in? Obviously, no cost sharing, but anything else they, you know, anything different for them? We got, you know, the initially it was just going to be 30-day script, which it would be really difficult to get it refilled every 30 days. So we got that changed and waived. But what else do you anticipate on the the PrEP user side?
Yeah. So again, I think just that pharmacy experience is going to be a make or break moment. Given that a portion of the Medicare patients are going to be older, they're going to have other medications. This is going to feel very heavy on trying to have them try to figure out the solution. So I think that that's the main issue. Now, if they found the pharmacy or they have a pharmacy that's doing the billing, I think it's a great thing. They'll understand there will be no copay and they'll be able to get the education they need and maybe some intermittent testing for STIs and HIV. I think that's wonderful. But unfortunately, I think that there might be a majority of the population that's getting PrEP as Medicare, not necessarily going to one of the HIV specialized pharmacies that are around the country.
Good point. Okay, we only have a couple minutes, and so it's going to be rapid fire, one person per question. So Bill, what happens if the NCD is not finalized?
Wow. I think a number of things happen. We maintain kind of in a status quo footprint or position as it relates to how people are able to access PrEP if they're a Medicare enrollee currently. That means there will continue to be challenges with copays for folks. You know, our clinic is different. We know this. This is part of our mission. It is our raison d'etre to serve folks living with and vulnerable to HIV. We bend over backwards to do everything we can to serve the folks who come to us. That is not the same experience that everyone gets everywhere. And I'm not trying to be disrespectful to anyone. It's just not. And so for folks who aren't getting their PrEP from a pharmacy and a clinic that's used to doing that level of work, what's going to happen? So that's, you know, that if nothing changes, folks will still have cost sharing barriers. Folks will still see those other barriers as it relates to the ancillary services, the testing, the counseling, et cetera, that's still there. So, you know, this is a little bit of being stuck between a rock and a hard place of how do we make this work? Because I really don't want to see the NCD not happen.
Yeah. So, Erin, we know that there's new long-acting PrEP on the horizon. How does this coverage determination impact future long-acting drugs?
I think no matter what those long-acting drugs, right, they're part of this this package of services that are going to be covered without cost sharing. I think the pieces that we're still working through, like Bill indicated and Glen has talked about, are just how are those going to be reimbursed, and how do we streamline that part of this process to ensure it's as seamless and smooth as possible for beneficiaries and frankly for providers, so that especially given it's going to go through Part B and people are going to need to enroll in Part B and may not have been familiar with that process, which there's a lot of additional paperwork and documentation to be a Part B provider. We need that to be as easy, streamlined as possible. And things like prior authorizations, those things we really don't want, because we need to see this move in as easy a fashion as possible. And we don't want anyone left behind. Typically when people get medication, they're going to one pharmacy, and we see with diabetes and certain other things, when they need to get the durable medical equipment, through a Part B pharmacy, often this is a place where they go without for periods of time because they don't figure out it's, where do they go, and it's not at the same location that they're using. So I think, we have these challenges to work through and overcome.
Okay, final question. It's a perfect one for you, Glen, because it's a pharmacy issue. So, oral PrEP could also be used for treatment. So when the switch happens, how is a pharmacist going to know if this is for treatment or for prevention?
So that is a great question. And I think it goes back to the pharmacists that are in the know versus just a pharmacy. And I think it's going to depend, as I said earlier on, is the rejection that may come from the PBM. So if you're the Medicare D PBM and you don't have to pay for PrEP anymore, you're going to put a block on. Now, I think what's going to happen is it's going to cause a problem for the HIV positive people.
Yeah.
They are the ones that now are going to be inconvenienced even more, because they're going to say, hey, I get this drug for 30 years and this is the drug I need. And now you're telling me I have to go through steps. And it's not for the positive person, it's for the negative person, but it's going to impact the people living with HIV. And that is going to be a bit of a challenge for providers as well as patients, and of course pharmacists, to try to get through that.
Okay, so we still have some unknowns. Well, thank you, panelists. And now you guys are still on, but we're also going to bring in some of our CMS experts, Jason Bennett, who is Director of Technology, Coding, and Pricing Group, and then also Joanna Baldwin, who is the Acting Deputy Director of the Division of Policy Evidence Review at CMS. And so I hope you are here. And there's Joanna and Jason. Hopefully, yep, Jason's here. So we thank you for being here today, and hopefully you heard some of the conversation and some of the questions that people still have, our experts have, the people in the know. But we thought that it would be great, since you're here, if some of our experts, they may want to ask you a question or two about some of their outstanding concerns. So who wants to go first?
Maybe I'll jump in.
Glen's ready.
I'm ready. We maybe are a little confused on the date of implementation versus the date that you actually activate the NCD. So is it January 1st where it would be actually in place, or would it be earlier than that?
Joanna, you're on mute. And Glen is probably asking that question because the reimbursement fee schedule came out and it's effective January 1st. So we just had a little question there.
Perhaps I can start by addressing part of that question, and Jason can perhaps pull up the other sections to answer that question. So if it's okay, I do want to thank you all for having us join you today. I am glad that we've been able to meet with many of you before. It's really nice to come on these big calls and have some familiar faces. We greatly appreciate that. And just the continued collaboration has really been incredible. Your support for this NCD, at the same time making sure that we have a full understanding of the impact and can do all that we can to mitigate potential problems that you've been able to highlight for us. Just on the surface, it's already drastically changed the way we communicate information prior to issuing a final NCD, and I think that's a really great thing in this case. Apologies, Glenn, let me pivot back to the answer to your question. So national coverage determinations are a little bit different in terms of their effective dates than, say, most of what the agency does, which is a lot of coverage payment and decisions through rulemaking. Rulemaking, you know, typically has that January 1 forecasted date. National coverage determinations and the coverage established within them, they are effective the day that they are posted. So with this one, as we've put in the technical FAQ, and as you have already said in front of us, which is helpful to get the word out, we have said September. The final NCD, we are forecasting for September. And in connection with that posting of that final NCD, that will be the effective date. So we're trying to get that date out as best that we can. But I'll turn to Jason if he would like to add anything.
Yeah, thank you, Joanne, and thank you for the opportunity to join you all today and help share some of this information and answer your questions as well. With regard to the question about payment, from the period in September when the policy takes effect to the end of the calendar year, our Medicare administrative contractors will be involved in the pricing at the local level with which they manage their jurisdiction. We have issued a proposed rule describing how we intend or how we propose to pay for these products for the long term. And that proposal, was issued yesterday and is now open for public comment for 60 days, and we would welcome your comment on that. And that proposal discusses our planned methodology for making payments beginning January 1st, 2025.
Thank you.
There will be an interim period where it's priced by our administrative contractors.
Right. So we're way over time because we have lots of Q&A. So one of you, Bill or Erin, who wants to ask a question? Okay, Bill.
I was pointing to Erin. I was letting Erin go next.
I will happily ask.
Erin, go ahead.
All right. Given the timeline for processing Part B supplier applications, and the launch of this, how long do you expect the timeline to be? And are you concerned at all about the ability to get through that whole process with site visits and other things, given that many people have not realized until recently that they need to enroll?
Yeah, again, if it's okay, I can take this one first. So, I think the short answer is, I think our level of concern has been made clear by trying to get so much information out in advance with the fact sheet a while back, following up with more detailed information about enrollment and how important that is. And please complete it now. If you have not started, please get moving. I think I say that only because we are taking that very seriously and trying to push that out. And we appreciate all of you on the call who are also trying to help us get that to the right people. There are, we try, while we can't instruct pharmacies on what they precisely should do, we did in the technical FAQ that came out in June, tried to suggest perhaps the lesser of two evils in the past of enrolling in Medicare in order to be able to bill for this. So we are certainly trying to encourage them to take that path that is ever so slightly less resource intensive. And we think that could be a faster path to Medicare enrollment.
So,
and that, just to be clear, that is the part, I'm sorry, Carl,
oh,
that's
go ahead,
the Part B supplier as opposed to a DMEPOS supplier.
So I'm gonna, we're running out of time because we want Q&A from the audience, but one thing, you know, maybe Joanna, I'll ask a question. What are you doing to educate people in the field about this? Again, we're with experts, and this is very, if you've been on for the last hour, it's very, very confusing. And so what are you doing to educate the people in the field to do this? I know you put out the FAQs, but what else, you know, how are we going to get this information out to everyone?
Yeah, well, we certainly continue to look for our partners out there and all of the interested parties to keep pushing this information out to the folks who need it. We are trying to do the same on.
We lost you, Joanna. Joanna, we lost you.
Wait, sorry, can you not hear me, Carl?
Yeah, no, go ahead. We're trying to get and then you cut off.
Oh, okay, I'm sorry. So, you know, we continue to try to get the word out there, the fact sheets. One of the things that we are working towards doing as quickly as possible is, you know, we do have the direct line of communication with the Part D sponsors and with the plans. So we have separate avenues of communicating directly with them through memos and things like that. And that process is also kicked into high gear to make sure that not only do we just post these fact sheets on our website and certainly push them out through all of our listserv connections, but also to go straight to the plans and the sponsors and ask them to do the same with the pharmacies that they work with to really try to get information through multiple avenues, if at all possible.
Okay, thank you. I'm sure Kevin and Leslie are really mad at me because I went over, but I'm going to turn it over to Kevin Herwig with the HIV and Hepatitis Policy Institute to start the Q&A. Thank you very much, panelists.
Great, thanks, Carl. So we have a lot of questions in the Q&A. Please don't hesitate to put any questions you have in the chat, and Leslie and I will elevate some of these great questions to the panel. Why don't we start with a question from Matt Pignati, who says, antiretrovirals for treatment and prevention are protected from prior authorization and step therapy requirements under Part D, but Part B lacks a similar formal rule. Has CMS clarified that they will continue these protections for PrEP under Part B? Jason or Joanna, I don't know if you might want to take a stab at that.
Or Jason and I are looking to see who comes off mute first for this one. You know, so unfortunately, we don't have anyone today on the call. It's just Jason and I. So we don't have anyone specific from the Medicare Part C side of the house that could speak to this with all of the very proper and accurate terminology when it comes to Part C and all of that. But, you know, Part C plans, you know, they do cover, and this NCD aside, Medicare Part C covers all of the items and services that are covered across national coverage determinations. So NCDs are binding on Medicare Part C.
Thank you. Thank you, Joanna. If I understood you correctly, you were talking about Medicare Advantage plans, which was another question that came up. But so yes, the question of prior authorizations is open. So there are a number of questions also. Is there a way for people to look up if a pharmacy is enrolled to bill Part B? Because especially we would hope that the number of pharmacies enrolled will be growing.
Yeah, I can start this question. We do have a supplier directory that's available for DME post suppliers, and that would include pharmacies who have enrolled as DME post suppliers, and would be a potential avenue with which beneficiaries could locate information in the short term. Also, beneficiaries can always reach out to 1-800-Medicare if they are having difficulty finding a resource in their community, whether it's for PrEP or for any other Part B or any service that that is covered by Medicare, and that they will do their best to work with the beneficiary to help connect them to the appropriate resource.
Thank you. So we have one question that asks, why are we doing this? Generic Truvada is $35 at all pharmacies. And that's a question which is, I think many might be able to weigh in on. Carl, maybe you want to start?
Oh, well, this is really for the long acting. It's to get ready for the long acting. And so that's an easy answer there. It's Part B handles, physician administered or, injectables and things like that. So that's why they're doing this. What we wanted was to maybe keep the oral in Part D, like it is now, because everyone says it's working, and move the long-acting, the injectable, to Part B. CMS came back and said they cannot, they don't have the authority to do that. So this is how it is. But we've been on this adventure for the last year to try to figure this out and make it work.
And if I could add, and I want to thank Erin for pointing this out earlier when as a panelist, in addition to the drugs themselves, the unique opportunity under the national coverage determination is also to bring in the related services. So again, you've all been reading what we've put out there, but the proposed decision and the number of counseling sessions that will be available without cost sharing, the additional screening tests that will also be available without cost sharing. Those are in addition to the drugs themselves, and something that we can only do through Medicare through a national coverage determination with our very specific statutory authority for additional preventive services.
Thank you so much for that, Joanna. Again, we really appreciate your shared willingness to answer these questions. I know that collectively you all sort of touched on this a tiny bit, but I think it maybe deserves a little bit more time. And it's sort of along the adjudication issue and the potential impact on some smaller pharmacies. Can you sort of talk through how you I guess will protect smaller pharmacies, independent pharmacies, from the burden that not having like immediate adjudication for the medication would produce, I guess. Thank you.
Yeah, I think some of the question is related to intermediaries that are not necessarily directly involved with Medicare and such as the PBMs and other partners. And so I think it is important that, like you all, they're ready on day one. One of the aspects of this benefit being an additional preventative service and billable under Medicare Part B, as the statute requires for additional preventive services. The billing will be to the max directly under original Medicare, so to our Medicare administrative contractors through the typical claims process used for Part B claims. So it will be functioning slightly differently than some may be accustomed to when adjudicating drugs with D, but again, that depends on the software and the setup of the particular pharmacy, and so I think a single answer is difficult in that particular question because it depends very much on the particular package of software and protocols that a pharmacy has established, as well as any protocols that other intermediaries have engaged.
Thank you so much for that. Obviously, more complication ahead of us. We are at time, unfortunately. I know that we all know we could take this another 90 minutes and still find a rich discussion, but I just want to say one more thank you to all of you, all of our great panelists, and Carl and Kevin, and particularly our partners at CMS. So everyone, we will send out a recording, but I think, can just look forward to additional conversations. Thanks so much, everyone.
Thank you.
Thank you.
Thanks.